It's all right. You've introduced yourself.
Yes. So thank you. So Louis has very nicely set the stage and described the description of the ADKI and the technique, the modalities, and I'm going to discuss a little bit into more detail some of the potential indications, and we are going to then focus on a different point that I want to make. So I also have some disclosures. And so these potential indications, there are different logos here. I'm going to really, for the purpose of this talk, focus on two, probably because these are the ones that are the broadest of interest and potential clinical application. One will be covered by the next speaker. I'm just going to set the stage for himself so that we can move on nicely through the session. So cardiac surgery, sepsis, and I mentioned burn patients, burn trauma, and also COVID-19. So starting with cardiac surgery, as you all know, cardiac surgery is a very common procedure, and it's associated with a very strong insult to the body because you are going to do a very massive intervention. It's associated with a cardiopulmonary bypass, and it leads to systemic inflammation and the release in the circulation of pro- and anti-inflammatory cytokines. And in some patients, when this release is out of control and too high, it would lead to systemic vasodilatation, organ dysfunction, and potentially acute kidney injury. This is really a sepsis-like syndrome that has been attributed to this cytokine release. And it's very tempting in this context to introduce hemoadsorption because we have cardiopulmonary bypass, that is an extracorporeal circulation that's already here running, and it's very easy and simple to introduce the cartridge and do hemoperfusion right at the level where cytokines are formed or the inflammation is generated. So we had two pilot trials that have been conducted, one in Austria and one in my center a few years ago. Both were quite similar, and when including elective patients undergoing elective cardiac surgeries, and both are quite similar in that they were pilot study designed to demonstrate the feasibility and the safety of the procedure, and they did. In particular, in our center, we focused on the coagulation parameters, and we have not found any significant adsorption, removal, clearance of coagulation factors. There was a mild activation of coagulation and a mild heparin adsorption. But certainly in none of these trials there was adverse events that were attributable to the device. So it's feasible and it's safe. And in both this trial, we failed to demonstrate the benefit in terms of the outcome, which was the decrease in cytokine level, mostly because if you're familiar with these measurements, they patients in both groups have very low IL-6 level, and of course we measured all sorts of other cytokines, but IL-6 were very low in the two groups, so it isn't unsurprising that an effect would be found in this. It would not be found. Another study using the Jaffron cartridge recently was conducted, and in this patient, I don't know how they performed the surgery, but there was a slightly higher group in terms of size. But in this group, the inflammatory response was higher, and in this group, there wasn't a statistically significant decrease in the release of cytokine, as you see on the slide, and this translated into a lower decrease in ventilation time, ICU duration, and the need for vasopressors. Of course, the world is complicated, and a larger randomized controlled trial conducted in patients with endocarditis, a situation where you would expect a very high inflammatory response, was conducted, and it did show indeed a decrease in the inflammatory response, as shown on the right side of the cartoon. IL-6 was lower, IL-1 beta, IL-18, all these cytokines were lower in the intervention group. However, this did not translate this time into clinical benefit, and the primary outcome, which was a decrease in the SOFA score, was negative. Another interesting situation, as I was already alluded by Lou in the previous talk, is the fact that we can remove molecules that we know they're in the blood and they should not be there. And in cardiac surgery, it can be particularly interesting when we have to perform emergent cardiac surgery, and the patient does not have time to stop their antiaggregant antiplatelets medication or anticoagulation platelet. And this paper, which was retrospective, observational, suggested a much lower drainage, so bleeding essentially post-operatively when hemoadsorption was perfused during the procedure. So that was, I think, of great interest, and it opens the field of removing something that we know. And of course, if this is true and you have the ability to work, then you can do cost analysis, and very likely this is going to be covering the cost of the adsorption, and this will be cost effective according to this analysis. So basically, to wrap this up with cardiac surgery, and then the next speaker will go into more detail with that, we can say at this stage it's safe, it's easy to apply, it might be efficient in patients that have a very high inflammatory response, but how to identify them pre-operatively, or at least peri-operatively, because you have to decide to put it while it happens. And it might minimize blood losses and certainly drainage in emergency procedure in those patients that are treated by these medications cleared by the system. So now moving to sepsis. As you all know, sepsis being a dysregulated response from the host to an infection, characterized by a first phase of very high inflammatory response followed by the immunosuppression phase. And of course, in this very high inflammatory response, this is where hemoadsorption could be efficient by removing this peak and normalizing or decreasing the volume and returning to a more physiological situation. This would also restore the gradient. By decreasing the concentration of the cytokines in the blood, it will increase proportionally the gradient towards the infected cells, the infected tissue where the white blood cells are needed, and they are directing their inflammatory response towards the area where they are required. So again, in sepsis, the level of evidence is relatively low to support hemoadsorption. There's been case series. I'm just going to show you one because it's quite striking. 12 consecutive kids with very high inflammatory organ dysfunction scores that were treated with hemoadsorption and had a decrease in their gravity score within 24 hours. So very rapid improvement of their hemodynamics after the therapy for a few hours. Of course, we had a randomized control trial that was conducted a few years ago, and this trial failed to demonstrate a benefit either in IL-6 or pro-inflammatory cytokines or secondary outcomes. A more recent trial in patients with septic shock compared this time hemoperfusion with high-volume hemofiltration versus CVVH. This study showed a minor decrease, but statistically significant in all the different pro-inflammatory cytokines and a faster improvement of hemodynamics. I think the key here is how to select the patient that would benefit from the therapy. I guess clearly if we take any septic patient, put them on the adsorber, it's unlikely that all of them will benefit. We need to demonstrate that some, and cherry pick those that will benefit. And this is illustrated by two papers. This one was looking at the results from polymyxin. As you might know, polymyxin B hemoperfusion is very commonly, it's a form of hemoperfusion that's commonly performed in Japan. And they did this retrospective analysis, and they stratified the relationship between mortality and time with according to the SOFA score of the patient. And as you see, those patients that had a very low SOFA score between 0 and 6, as well as those that had a very high SOFA score between 13 and 24, they did not benefit from the hemoadsorption, while those that had an intermediate, so not too sick, but sick enough, these one appeared, based on this retrospective data, to benefit from the hemoadsorption. And this is consistent with a secondary analysis of the Euphrates trial. You might remember the Euphrates trial was also trying to assess hemoperfusion with polymyxin, and they had an endotoxin assay to ascertain that the endotoxin was positive in the patient. It was a multi-center randomized control trial that was negative regarding its primary endpoint. And they did this secondary analysis that was published a few years after, where they only focused on those patients that had an elevated endotoxin activity assay, but not too high, so 0.6 to 0.9 essentially. And in this range, as shown on the figure on the right, there was a statistically significant improvement of mortality. So it's not to say that this is evidence-based, of course. I think the question is really, we need to identify the small window and the number of patients that can benefit. Probably these patients are not too sick, but sick enough, and this is easy to say, but it's much more difficult to establish in clinical practice when you're in front of a sick patient. So determine which patient. And the second question in sepsis is we are going to use a therapy that's going to remove drugs from the blood. And of course, the one therapy we know that is efficient in sepsis is antibiotics. So what about drug removal? What about antibiotic removal? And I think at this stage, before we start organizing more trials, we have to step back and look at physiology and understand how this all works. So this is a work we did a few years ago with CytoSorb, where we looked at the capacity of this filter, this adsorber, to remove the antibiotics. There was a study conducted with 24 German pigs, and we administered some combinations of antibiotics to these animals, and we performed to 12 of them a CytoSorb adsorption and 12 of them a sham procedure. And of course, we did some blood samples, and the key thing I want to bring here is the following. Look, this is the clearance from all these medication. You can look at the names. There's many of them. It's the ones we use very commonly at the bedside. And for all or most of them, the vast majority, there is a clearance. There is removal by the drug. So we have to be wary that we are removing some antibiotics. However, one of the things that we did when looking at the data is the fact that you have to consider the clearance by the extracorporeal device, but you have to put it in relationship with the endogenous clearance, because obviously the medication is also cleared by the liver, by the remaining of the kidney, if it's functioning, and all the other cells. I mean, essentially, there is a clearance of the drug. And then if you put this clearance, these are the dark gray bars, in proportion to the white bars, which is the removal by the animal, then the picture looks very different. And you'll notice that for many of the medication, the clearance, the added clearance by the system is actually very small compared to the endogenous clearance. However, for some drugs, for instance, fluconazole, linezolid, and amphotericin B, they are significant. They're actually really increasing the clearance. So my point here is that we need to know, we need to understand which drug, how to adapt the medication, when, etc. And another thing in this study is we looked at the kinetics of the antibiotics removal. And I think that's very interesting because it's not something that is linear. You put the adsorber and then you have a certain removal every hour. No, no, no. The first hour, you look at here, these are the beta-lactams. The first hour, there's a huge removal, and this is slowly sloping down, decreasing over time, with even desorption in the 6 hours. The study was conducted for 6 hours. So the molecules were sticking, and after a certain amount out, they were being released in the blood, leading to a negative clearance. So this is the same. We've seen that the antifungal drugs were removed at a very high level, and you see that it was more sustained, at least for fluconazole and posaconazole. But again, it changes from one molecule to the other. And here I'm just going to show you some data for all the medication, but we can't go for all of them. I'm going to focus on tobramycin, because tobramycin, I think, is of particular importance because you see that all the clearance of this medication, nearly all of it, happens in the first hour. So essentially, you give tobramycin, you can do hemoadsorption, you remove the drug, and this is, in a way, something that could be an indication somehow, because you know that tobramycin, we want a high peak effect to have the killing effect, and then you want to minimize the residual dose to avoid the toxicity. So this has been conducted with CytoSorb, and again, as Louis has said, not all hemoadsorber are the same, and we want to replicate this data with the Jafron cartridge, the HA380. And you see here my mentor, Rinaldo Bellomo, who is, of course, from Australia. And he's being Australian, he doesn't want to work on pigs, he wants to work on sheep. And so that's all the drugs that he's trying to test, and we're working together on this project, and it's great. But because he cannot wait, he's already published a paper. That's Rinaldo, if you know him, that's how he does. So he's already published a paper on vancomycin and gentamicin, just came out last week. And the findings are very much compatible to what we found with Cytosorb, essentially. First, it was well tolerated, the cartridge, and there was a very strong initial adsorption. The removal was very high in the first hour for vancomycin as well as for gentamicin. And then there was a slow decrease in the removal rate and sorbent-based clearance. The data for this particular drug suggested that the drug would need to be topped up by about 25 to 30%, and that's their interpretation. So then that's going to bring me to my conclusion, and here I'm going to quote Claudio Ronco and Rinaldo Bellomo again. We have, and this is similar to what Louis just said, we need to know more, understand more. We need to define adequate, optimal, safe dosage of hemoperfusion for different disorder. One size might not fit all patients. We need to study how best to measure efficiency and efficacy, the number of sessions, the duration of the sessions, how often should we replace the cartridges, and we should focus on clearance, excretion ratio, mass removal, and performance for key biological targets. And for now, I think we need to step back, understand the therapy before organizing more massive randomized controlled trial. With that, I want to thank you very much.